Very good evening, one and all, and warm welcome. We have gathered here for an academic feast that is to follow. As we all know, cardiovascular disease accounts for major morbidity and mortality across globe. India too shares highest burden due to attributes like clustering of cardiovascular risk factors, early age of cardiovascular disease onset, rapid progression of disease, and high mortality rate. Today, we are here to understand, gain insights, and learn on latest updates and advancement in cardiovascular therapy as discussed in recent ACC conference. We have two eminent speakers with us, and I have the honor of introducing and welcoming them. For the first talk, we have renowned Professor Dr. P.C. Manoria, sir, as our esteemed faculty. Sir is director. Sir is director of Manoria Heart and Critical Care Hospital, Bhopal. Former professor and head of Department of Cardiology, GMC Bhopal. Has been past national president of 9 National Association ACC. Has been awarded 7 Lifetime Achievement Award during the WCCPC 2008 by Bharat Ratna Honorable APJ Abdul Kalam sir, and at Indo-US Conclave 2023 by Dr. D. Armstrong. Sir has organized several national and international conferences for last 40 years, has been executive president at World Congress Cardiometabolic Medicine, has edited 35 books and has 82 publications in various reputed journals. And also, sir has delivered more than 800 lectures in various national and international conferences. We welcome Manoria, sir. And for the second talk, we have Professor Dr. Michael Bloom. Sir is Chief Editor of European Journal of Heart Failure, Board Member of European Heart Failure Association, past Chief Editor of Clinical Research in Cardiology, Consulting Editor in Basic Research in Cardiology, also Editorial Board Member in Hypertension, and is also reviewer of major journals, prestigious journals including Circulation Research, Hypertension, Lancet, JAMA, NEJM, and many more. So we have the privilege of having both with us. And without further ado, I now hand over the session to our first esteemed speaker, Dr. Professor P.C. Manoria, sir.
So, good evening, everybody. Some moments are so rare and special, and indeed, is such a moment when we have gathered here to discuss the late breaking trials presented at the 75th anniversary of American College of Cardiology at Chicago. First, I'd like to pay my respects to Dr. Bohm, who I am a great admirer. For the next 30 minutes, I will be talking on from research to practice, the future of cardiovascular care. Medicine is essentially a resolution of uncertainty, and this has time and again been proved on several occasions, and it aptly applies to cardiology, where research continues unabated 24 into 7 into 365 to provide us better understanding of the disease process, innovative technologies, and innovative molecules. The first set of trials which I will be presenting pertains to structural heart disease. And the first trial is the ALIGN-AR trial. All of us know TAVI is being extensively used across the globe for patients with severe aortic stenosis. But this trial enrolled patients of moderate to severe aortic regurgitation who had high surgical risk, and this trial 500 patient moderate to severe symptomatic AR were enrolled. The follow-up was 2 years and the mean age was 76.6. 46% were female, and unicuspid or bicuspid aortic valve, ascending aorta more than 5 centimeters, CAD requiring revascularization were the exclusion criteria. The primary endpoint, the primary safety endpoint, was a composite at 30 days based on the WAC2 definition, as you can see on the slide, and the primary efficacy endpoint was all-cause mortality. Non-inferiority criteria met for the primary safety endpoint as well as the efficacy endpoint. There was improvement in the echo parameters, LV remodeling, NYHA class, KCCQ score. RBB was a predictor of pacemaker implantation, and the mortality was very low. The results were positive, and this trial provides the first dedicated tower option for symptomatic patients with greater than 3 plus AR who are at high risk for surgery, and is well positioned to become the preferred therapy upon approval for this population. So this is going to be a boon for patients of moderate to severe aortic regurgitation who are high risk for surgery. And I'm sure this is likely to be approved in near future for this subset of patients. SGLT2 inhibitors continue to surprise us, and we continue to learn, and this time they surprised us by the DAPA-TAVI trial. This is the first trial of SGLT2 inhibitor for valvular heart disease. In this trial, 1222 patients, median age 82.4 years, 49% females, and all patients had severe aortic stenosis, and DAPA was introduced within 14 days of hospital discharge after TAVI. DAPA 10 milligram was compared with standard care alone in patients with aortic stenosis who were undergoing TAVI. These patients had history of heart failure with at least one of the following conditions: renal insufficiency, diabetes, or left ventricular systolic dysfunction, and 620 patients were randomized to receive dapagliflozin and 637 to receive the standard of care alone after TAVI. And as you can see, the primary endpoint, which was all-cause death from any cause of worsening heart failure, there was a statistically significant reduction of 38%, as you can see here, mainly driven by 38% reduction in worsening heart failure. Death, of course, only showed a numerical benefit. So this trial also showed us that SGLT2 inhibitors are safe in elderly patients. Some of the patients were even plus 90. And heart failure in aortic stenosis is multifactorial. We should not presume that if we have done TAVR, heart failure doesn't require any treatment. The third trial is the EVOLUTE trial, which is tried to compare low-risk patient TAVR versus TAVR and at a 5-year follow-up. 1414 low-risk patients with aortic stenosis underwent AVR and TAVR, and the mean age was 74 years, 35% were females. The primary endpoint, as you can see, death or disabling stroke, there was no difference. And the 5-year results of this trial provides compelling evidence with no significant negative signals for TAVR. So whether you are looking at the CV mortality or disabling stroke or non-CV mortality, all of them were non-inferior. But the problem with TAVR is we do not have very long-term data of TAVR, unlike SAVR. So if we are trying TAVR in a young population, we have to have a very long-term data, which at the moment is not existing compared to TAVR. Now, this trial pertains to tricuspid regurgitation, which is not uncommon in patients with valvular heart disease. All of us know when a patient has moderate to severe tricuspid regurgitation, it interferes with the quality of life, it produces hepatic congestion, it also results in hospitalization for heart failure and even mortality. And this trial tries the H2H repair just as we have done in the mitral valve, what would be its impact on the various parameters. So 350 patients, 175 assigned to each group. Mean age 78 years, 54.9% were women. And as you can see, there was a significant reduction in the TR. The magnitude of TR decreased significantly. The functional class also decreased significantly. And as you can see, the quality of life also increased significantly. So this is again going to be a boon for patients of tricuspid regurgitation who are not fit for surgery, who are on optimum treatment. And usually the surgeons are also reluctant to take these patients because they often have other concomitant valvular heart disease and other problems also. Now, integration of genomics in cardiovascular care has enabled personalized treatment approaches to tailoring to individual genetic and molecular profiles. And the trial which I'm going to discuss is the Alpaca trial, which is based on gene silencing. And this trial tried to assess the effect of lowering LPA levels. All of us know we do not have any approved treatment for LPS yet. And lepotiseran, which is a small interfering RNA in trial, when injected in a dose of 400 milligram, as you can see, there was 93.9% reduction in the LPA levels, and even after a second injection at 180 days, it was around about 90%. So again, a very, very impressive result, although this is a phase 2 trial, 320 patients, a median baseline LDL was LPA was high, 253.9 nanomoles per liter. So very encouraging results. And this is a small interfering RNA, which reduces the production of LPA in the liver by disabling messenger RNA that is involved in producing ApoA, a key component of the LPA particle. Two others, small interfering RNA, are being evaluated in phase 3 trial. This is the Ocean trial with olpasiran and Alpaca trial with zerlesiran. And we now have also an oral molecule, movalapin, which NHA presented last year in the Kraken trial. Now, this is another trial, prolonged N3 trial, which tried to assess the effect of another small interfering RNA, solbinisiran, in patients with mixed dyslipidemia by targeting angiopeptin-like protein 3. And you can see significant reduction in the triglyceride levels. You can see that this is almost up to 60% at 180 days and almost 50% at 270. Again, significant reduction, around about 60% at 180 with VLDL cholesterol, and at 270 days is around about 40% or so. There's also a significant reduction, around about 30% at day 180 with LDL, and non-HDL also around about 30%, little more than 30%. But this is a preliminary trial, phase 2 trial, and more data is needed for this agent to be tested for CV outcome in phase 3 trials. Now, gene silencing with ASO therapy is another important way to silence gene, and antisense drugs block the translation of specific targeted protein. And all of us know pelacarsen, which although not presented in this ACC, the Horizon trial is ongoing and very likely to be released late this year or early next year, is an antisense to ApoA, prevents the synthesis of ApoA by ASO technique, and the Horizon trial is ongoing. All of us know LPA-driven cardiovascular disease is considered a slow death sentence with gloomy prognosis because of premature development and malignant progression of ASCVD, also associated AS, and currently lack of any approved therapy. And if pelacarsen and small interfering RNA trials, if they come out to be positive, LP-induced cardiovascular disease will become a salvable disease in future, and this will kick off a new dawn in LPA therapeutics. Gene silencing, although was not discussed, but was discussed during last HA, but it's worthwhile spending half a minute on this very exciting therapy. This works on CRISPR-Cas9. It is a two-component guiding RNA which guides the specific genomic locus in the Cas9 nuclease, produces a double-stranded block a double-stranded cut at the specific genome locus. As you can see on this video, the guiding RNA has located the gene, and the Cas9 nuclease will produce a double-stranded break at the specific genome locus. And when this heals, this PCSK9 gene loses its function. It becomes a case of loss of function mutation, PCSK9, and the WAVI 101 trial is ongoing. And some of the patient has been successfully treated. One of the patient, 89% reduction in PCSK9 after 1.5 milligram per kilogram, and 68% reduction in LDL. And the beauty is that only a single time treatment, the effect lasts for the whole, although this technique again is being evaluated. The other interesting trial was a Pursuit trial, oral PCSK9. We have injectable monoclonal antibodies, evolocumab, velarocumab, and small interfering RNA inclisiran. But this is an oral PCSK9 inhibitor because many patients are very reluctant to take injectables. So the patients were 62 years old. On an average, 50% were male, mean LDL 100.7, 40% were taking a moderate intensity statin, 60% on high statins and ezetimibe. And this was a double-blind phase 2 study conducted at 50 sites in North America and Europe. 28 patients were enrolled, and they were given different doses. And you can see 51% reduction in LDL at the 30 milligram dose, and the adverse effects were comparable to the placebo. Then we have very interesting GLP-1 receptor agonist trial, the SOUL trial. Obesity, all of us know, is rocking the entire universe and is now a disease and no longer a risk factor. It's a potential to produce various cardiovascular diseases. The big question is, does anti-obesity medication improve CV outcome? And the answer is yes, because with ACC 25, we had the SOUL trial, which was positive. SELECT was a positive trial presented in past, which improved ASCVD outcome, a secondary prevention trial. And we have also data from the SUMMIT trial, which showed improved outcome in HFpEF, and the SURMOUNT trial for OAS, which is also positive. Now, this is again a very landmark SOUL trial, 9,650 patients, 4 to 5 in SEMA group and similar patients in OSA. Patient has known ASCVD, CKD or both to receive either once daily oral semaglutide, maximum dose 14 milligram, in addition to the standard of care. You can see the baseline characteristics. Age is 61.1 year, HbA1c means 8. The range was 6.5 to 10%. Long-standing duration 15 years. Obese patient, BMI 31 or more. Oral glucose lowering agent, all standard of care, and 25% or 26% were on SGLT2 inhibitors. And the benefit was seen irrespective the patient was on SGLT2 or not. So both agents can be used together also. Major chunks, CAD 70%, CKD 42%, CVD 21%, PAD 15.7%, and HF 22%. Adverse effects were comparable to the placebo, 18.9% and 22%. GI side effects were more common, 6 to 8% versus 1 point. And these are the results. The trial was positive. The primary endpoint of cardiovascular death, MI and stroke, was reduced by 14%, which was statistically significant. There was a reduction in death, a numerical reduction of 7%. Non-fatal myocardial infarction was reduced by 24%, and non-fatal stroke again was reduced by 12%. Major kidney, again, a numerical reduction of 9%, and major limb events also showed a reduction of 29%. The same molecule was utilized in the STRIDE trial in peripheral arterial disease, and this is the data from the STRIDE trial, semaglutide 1 milligram weekly versus placebo, symptomatic patients of peripheral artery disease and type 2 diabetes. This was especially in type 2 diabetes. And the patient to have early stage symptomatic PAD, pain-free walking distance more than 200 meters, and maximum walking distance less than 60 meters, ABI less than 0.9, or toe brachial index less than 0.7. 792 patients, semaglutide 1.0 milligram, 52 weeks, follow-up 57 weeks, and the mean age was 60, 24% of female. And the trial was positive. It showed maximum walking distance was increased by 26.4 meters compared to placebo. Spain, free walking distance 29.8 meters, quality of life increased, fewer liver events. Some of these patients were not obese, and therefore this means that weight reduction is not the only mechanism. There could be mechanisms in the vasculature by which they improve the walking distance. Heart failure, again, this is again a changing practice trial. All of us have been practicing restriction of ibuprofen patients for treatment of heart failure, but this trial negated this old concept and clearly shows that restriction of fluid does not help these patients. The results are similar in both subsets of patients, whether you restrict fluid or whether you don't restrict. So fresh up trial again is a practice changing trial negating the beneficial effects of restricting fluids. Then we have the mighty heart trial. All of us know patients of heart failure, particularly elderly, they get re-hospitalized, and they can also have increased mortality, particularly after the first hospitalization. So this trial tried to assess two transition of care models to prevent hospitalization and improve the health status. 2003 patients who had been hospitalized for either a mobile integrated health program or a phone cell with a transition of care coordinator 48 to 72 hours of discharge. A patient could request in home visit that assess their symptoms in home environment in addition to setting up a laptop internet for a live visit with a physician. 34% also have uh, ischemic cardiomyopathy, atrial fibrillation, diabetes, and CKD, but no significant difference between the two arms in hospital readmission. Women were 30% less likely to be readmitted for all-cause hospitalization and 36% less likely to be affected. Patient less than 70 years old may be most likely to benefit from mobile integrated health. KCC scores improved in both the study groups, and the improvement with mobile integrated health remained the same in both groups, while younger patients saw less of an improvement with the transition of care coordinator. Iron therapy, all of us know, no doubt improves the quality of life. It is a class 1A recommendation, but the FEAR-HF trial was see whether it could decrease hospitalization for heart failure in patients with HFrEF and mildly reduced ejection fraction. You can see it failed to reduce the cardiovascular death or first HF hospitalization. Statistically, there was not difference, but there was a numerical difference. Total HF, again, there was a numerical difference, and so also CV death first HF hospitalization, again, much less. Perhaps if the trial had enrolled more number of patients, this could have shown uh, positive results in decreasing hospitalization for heart failure, but the trial showed only a numerical decrease. Then we look at the trials of ACS and CCS. Now, this is the RIVER trial for ALV thrombus post-MI patients, and this tried to compare rivaroxaban with warfarin. Warfarin is the only approved agent for treating LV thrombus, oral agent. But this trial showed when even you use rivaroxaban and compared it to warfarin, rivaroxaban was found to be non-inferior. So 261 patient rivaroxaban versus warfarin, 171 versus 90. For the first month, DAPT and rivaroxaban and DAPT plus warfarin, but later on, clopidogrel plus rivaroxaban and clopidogrel warfarin. But the results were same, so in times to come, we can use rivaroxaban for resolution of LV thrombus, which was 95% in both the groups. Host VR trial, again, was a very interesting trial. This trial tried to assess the strategies for high breeding risk and low breeding risk. Nearly 5,000 patients undergoing PCI with DES implantation. ARCG-HBR stratification was done. And you can see here when DAPT for 1 month was compared for DAPT 3 months, 3 months DAPT was superior, whether you're talking of NACE, MACE, or BARC 2 to 3 to 5 bleeding. And even in the low bleeding risk, as you can see, DAPT3, the green one, was superior compared to the DAPT for 12 months. This is the reverse IT trial. We have patients of ticagrelor who has a major bleed or they may require urgent hemorrhage. The antibody bentracimab was very effective in these patients. The action starts within 5 to 10 minutes and lasts for 24 hours. So in the event of a major bleed or patient requiring an emergency surgery, patient is on ticagrelor, this agent could be used for negating the effect of ticagrelor. And this is the conclusion of this trial. Now, smart choice, again, a very interesting trial. This tried to assess whether clopidogrel is superior, whether aspirin is superior. So nearly 5,000 patients, again, a Korean trial, 26 sites, median age 65, post 1 year CCI. This is a complex patient, all had prior MI, diabetes, complex CAD, and clopidogrel 75 versus aspirin 100 milligram. We look at the primary endpoint, a 29% reduction in the primary endpoint, all-cause death, MI, stroke. Uh, uh, you can see in favor of clopidogrel, death from any cause also favorably affected, and so also myocardial infarction and stroke. But this was an open-label trial and restricted to Korea. So the big issue is emerging. Will clopidogrel, the new aspirin, times to come? We had the host exam trial also in past, but again a Korean trial. We need more trials from other countries also before this can be true. But the concept seems quite logical. In both these trials, the clopidogrel was superior to aspirin. Warrior trial was seen in Inoka, and intensive medical therapy failed to improve the outcome, although this is a neutral trial, but I think more strategies can be designed in future to improve the outcome of these diseases. Cancer DVT again is a big problem, and this API CAT trial tried to assess the extended anticoagulant therapy with reduced dose of epinephrine 2.5 milligram twice daily. It was found that it was non-inferior to full dose in patients with active cancer and VTA. So you can see 176 patient, active cancer, proximal DVT, pulmonary embolism, who had completed at least 6 months of anticoagulant, was randomized 1:1 to receive oral epinephrine at reduced dose or full dose BID. The primary outcome was a centrally educated fatal or non-fatal recurrent venous thrombosis assessed by a non-inferiority, and you can see this non-inferior. And secondary outcome, clinically relevant bleeding assessed by a superiority analysis. So bleeding was also less, and the mortality also a numerical reduction. So low dose apexaban after 6 months is non-inferior to the full dose, but this data should not be applied to other subset patients like atrial fibrillation. This is restricted to cancer DVT. Hypertension, we have the advanced HTN trial with lorundrostat, aldosterone synthase inhibitor, and you can see this was carried out in patients with resistant hypertension on 2 to 5 drugs, and this produced additional reduction in blood pressure. You can see this was a 15.4 reduction in 50 milligram and 13.3 with 50 to 100 milligram. Side effects were comparable. And then we have a trial in pulmonary hypertension, Zenith trial. And as you can see, high-risk patients, adults with pulmonary arterial hypertension who were receiving the maximum tolerated dose of background therapy, when treated with sotatercept, has a lower risk of composite death from any cause, lung transplantation, or hospitalization more than 24 hours for worsening pH. This is the data from the Zenith trial. You can see 172 patient, 86 in the sotatercept and placebo group. And the primary endpoint, as you can see, is a composite of death from any cause, lung transplantation, hospitalization more than 24 hours. This was superior. And the trial was terminated prematurely because of efficacy result. And sotatercept targets activin and growth differentiation factors and helps to restore the balance between growth promoting and growth inhibiting factors. And you can also see some benefit in the overall survival and transplantation free survival. So thank you very much for your kind attention.
Thank you, sir. Thank you, sir, for that wonderful talk. Now we invite Dr. Boom, sir, for his talk.
So thank you very much. First of all, I would like to thank the organizers for having invited me to this interesting symposium. I was asked after the excellent outview and now summary of Professor Manoria to update you with hypertension. What is new in hypertension? We had recent guidelines from the European Society of Cardiology and the year before from the European Society of Hypertension. And there were some aspects also in the American Congress of Cardiology conference. So I will focus now on updates of hypertension. So these are my disclosures. I will talk on the size of the problem. I will discuss the population on the definition of hypertension in the population, which was rather unexpected in the European guideline. I will talk to treatment concepts, also about salt restriction, target values in aging and diabetes, RAS blockade, maybe independent effects on risk, how to achieve blood pressure goals and the role of single pill combinations, and some innovative drugs and technology. So this is what you see here, the global burden of hypertension, and what you can see that in these data, you always see that there is a huge variation of the world. It is not anymore a problem of industrialized countries such as in Europe. It's a problem indeed of sub-Saharan Africa and large parts of Asia. You have to acknowledge here that indeed all these evaluations are, of course, a little bit subject to reporting bias and to the intensity to detect hypertension in the populations. But what we should keep in mind that this is something which is progressing over age. It is something, it's still a disease, but it is something with physiological that indeed the blood pressure incidence is increasing over age. And I brought you this slide from the Framingham studies showing in patients above 85 at a follow-up of 20 years, that means up to 85 in women, and this is 85 in men, and in older times they did not even achieve this age. You can see if you become old enough, you have a prevalence of hypertension amounting to 80 to 90%. And still in these populations, of course, there is a necessity, I will talk about that later, to reduce blood pressure. And here you can see how the huge burden in our societies is and will become if the population still get older. Now, what is the consequence of increased blood pressure? This is here showing here. We have now deaths attributed to elevated blood pressure. And you can see that indeed in these patients and individuals, ischemic heart disease is one of the major causes of death. That's the largest causes because so many people have it. And you can see that is not only the extremely high blood pressure. This is a recent definition of hypertension above 140. Still, there is such an extreme load of deaths. You can see number one, ischemic heart disease. The other one is hemorrhagic stroke and also ischemic stroke. What is not listed here because it's not recent or is not adequately detected is heart failure. Now, it's a huge burden, and you can see the major problem in our societies is that we are untreated, showing the size and the importance of the problem. On the left-hand side, you can see women. On the right-hand side, you can see men. About 50%, regardless of sex, are not diagnosed. Among those diagnosed, only 50% are treated, and 23% in women and 18% in men are controlled. So these are data which are accounting for the load of disease over the whole world, and therefore that is a necessity to control blood pressure. But we as physicians, we have to see that our perception of whether a blood pressure is controlled or not is very limited. You can see this is an old study done many years ago, and there is a repetitive study here in Europe showing the same thing. The patients really think his blood pressure is controlled. That is important when you take the history of the patients. Only few patients have a reliable taking of their blood pressure. Then the doctor's perception is maybe it might be fine because I am giving a drug. But the reality, when you really take blood pressure, and at best ABPM is only 37%. So that is really something which is very poor. Here is a lot of room for improvement. Now, what is the new guidelines at the ESC, of course, really taking, and what is the take of them? The first, which many people commented when they saw the guideline, listen to the title, Guidelines for the Management of Elevated Blood Pressure and Hypertension. This suggests that there is a difference between elevated blood pressure and hypertension, two different entities. Now, why is that so? Indeed, there is a blood pressure below 140, and you can see here that cardiovascular events, and you can see this is about 25 to 30%. 30% of disability-adjusted life years occur in cardiovascular disease in patients below 140. So this guideline, which was mainly driven by epidemiologists, made the point that indeed all these hypertension-related problems occur at a lower blood pressure. And the problem is that these high, slightly elevated blood pressure is so common in the population that indeed this is a very important population which deserves a special interest. And what you can see indeed when then you look at the cardiovascular outcomes and you look at the high risk scores, then you can see that approximately 25 of the population with a blood pressure which is elevated, but not really in the hypertensive range, they have extremely high blood pressure, where blood pressure have extremely high risk scores, where blood pressure is contributing. And what we know that in this population with a high risk and borderline blood pressure, let's call it this way, they are really benefiting from a reduction in blood pressure. And here you can see the exact classification. And this is not only office blood pressure. Nowadays, we also take into consideration home blood pressure measurements of the patient, ABPM, as a gold standard. And what you can see, non-elevated blood pressure is really a low blood pressure between 100, below 120. There very rarely events occur. And you can see elevated blood pressure is 120 to 140, or diastolic 70 to 89. And then, of course, it is dependent how high the risk is on the accompanying risk, the global cardiovascular risk. And then in hypertension here, mainly the risk is driven by blood pressure. What you can see, this is what everybody can get, that is office blood pressure, that the levels of home blood pressure and ABPM, which is the daytime mean blood pressure, is slightly lower, yeah, indicating that here the margins are lower. You should achieve a blood pressure below 135, and then you are not in hypertension. Otherwise, it's non-controlled hypertension. So please take into consideration ABPM measurements and also advising the patients how to take blood pressure at home. So this is the definition of blood pressure. That is the concept behind the fact that blood pressure should be reduced potentially in some patients with only elevated blood pressure. Now the concept of risk in the global population. So I bring you back to this historical data from the Framingham study. And you can see there is, when cholesterol is really high, there is the global risk for coronary artery disease. That is what is depicted here, is really rising by a factor of 4 when you take these 7 groups. If there are no other risk factors, low blood pressure, normal glucose tolerance, no smoking, no hypertrophy, this amounts, if you just have glucose intolerance in addition to that, to 23. This increases when there is smoking to 34, and then when you have end organ damage, now we are entering the field of secondary prevention, then it's 60. contributes to the fact that low or elevated blood pressure, which are not definitely in the hypertension range, should be reduced, because this risk, together with slightly increased blood pressure values, are carrying risk. And therefore, these patients might have an indication for blood pressure lowering. Now, I just mentioned from Salim Yusuf, one of these most important studies in young men, but very young men, just in the Interheart study in many countries, including India. And you can see this is the odds ratio to get myocardial infarction is increasing exponentially. You see, this is a log scale to 512 if you take only these 10 risk factors. All risk factors increase the risk by 500-fold, and that indicates that having detected hypertension, and this is recommended in the guidelines, the accompanying risk, the global risk, should be detected by the risk scores, whatever you take. It's not so important. But then all risk factors should be treated and controlled. Now the question, can we say and can we answer the question, what is the contribution of individual risk factors to the global cardiovascular risk? And this is a study where they put together from different countries epidemiological studies, outcome studies, the different risk indicators, as it is shown here. As is Dr. Magnussen, a young doctor from Hamburg. And you can see that hypertension is indeed carrying the largest burden of risk. It's twice as high as non-LDL cholesterol. It's more than cigarette smoking and diabetes. However, as you remember, if they come together, then it gets really worse. This is a very complicated analysis, but you can see hypertension in women and in male are carrying the major risk. And that is the reason why we talk about this so frequently. Now, what is now the goal of blood pressure? Yeah, you can see cardiovascular avoidable risk events avoided. Here you can see systolic blood pressure reduction, and here you can see global risk. Here you can see the same thing for diastolic blood pressure. Please concentrate on the left-hand side. You can see people with blood pressure and a very high risk, right? They have an overwhelmingly increase of risk. And the reduction, this is the reduction of risk, is the highest. The higher the blood pressure reduction is, that is these columns, and it's the highest the basal risk is. So the higher the risk is, including already established cardiovascular disease or having had an event such as heart failure, hospitalization, or myocardial infarction or stroke, the greater is the risk reduction. Yeah, you can see 69 events per 1,000 patients can be avoided. If the risk at the same time is rather low, you have 18. So that is a factor of 4. It's the same here in high-risk patients. When there is a small blood pressure reduction, the risk is more than 10 times lower. So when you have a patient who has already something, the blood pressure needs to be urgently controlled. Otherwise, you run into problems and you have a tenfold increase of risk. So that was my take on it. I try to look at it from different angles. The problem is high risk means strict blood pressure control. Strict blood pressure control means less patients are entering the high risk group. Please look also at accompanying risk. So these were the take homes. Now, what are the problems? This is here depicted in the new guidelines from the ESC, and it is endorsed by several other organizations. Look into the eye to see end organ damage and the high risk patients. Look at the brain if you have the opportunity, at least clinically, look whether there is cognitive impairment, post-stroke, neurological deficits. Look in the heart with echo, hypertrophy, left atrial dilatation is one sign. The kidney, don't forget microalbuminuria, even as a cardiologist. Microcirculation, that's again the eyes or microalbuminuria, and look at atherosclerosis of the large vessels. So that is a quite simple workup, which can be taken in part by the medical history or by lab examinations or some technical examinations such as vascular ultrasound. So that is how to detect this. Now, what about treatment concepts? So I go a little bit back. This is a conference which was very important for Germany. This was a separation of Germany, which was decided in 1945. You see Winston Churchill, you see Franklin Roosevelt, the American president, and you see Joseph Stalin from Russia. And you can see this, he died. He had a hypertensive encephalopathy at that point of time. He had a stroke. You can see here the typical attitude of a smoke. He had a global risk as he was smoking. He was drinking a lot of alcohol and had a hypertensive mass bleeding. So that is, and it shows that this is a very common thing, that people, indeed, everybody can be hit by hypertension. And these three leaders have been hit all of a sudden. And with Franklin Roosevelt, this was particular a problem because you can see hypertension is triggered, there is a baseline risk by genetics and lifestyle changes, but it can be triggered by other things, such as the D-Day entering Europe of the United troops. You see, this was a quiet time for him. And then in the 1940s, it gets stressful. The D-Day was here. The election, where indeed another president was chosen here, this was a conference of Yalta, and there was an increase of blood pressure to 300 millimeters of mercury before he died, also to a mass bleeding, before he had severe kidney failure. In these three people, you can see all the different complications of hypertension. Now, there was an early approach, and this comes through lifestyle. In 1950, there was a German doctor who had to immigrate to the United States, and this is Walter Kempnert. He was the founder of diet. This is rice and an apple. That was how he treated patients. Then he got a day 2 pieces of blood, and you can see from this blood pressure, strict rice diet, then 1/4 of tomato added, and then a little bit of meat, and then added, you find a blood pressure reduction from 200 to 130. 70 millimeters of mercury in a 51-year-old male with malignant hypertension. And you can see during this rice diet, it went down to diastolic blood pressure below 90. So this is rather optimal blood pressure. So this is diet, but don't forget, this is rice without salt, right? Without salt. It is just this without salt, and this is really a minor amount. And these are where the patients were looking like. That was indeed the first study of the diet. They got simply slim, and of course the blood pressure was dropping. That has implication for SGLT2 and also for, in particular, GLP-1 therapy today. This is all associated to a blood pressure reduction when the weight loss is extensive. Now, this was the hypertension in the early days. This is a study on outcomes in 1939. Without medication, the death rate was 80% in 1 year when the blood pressure diastolically is greater than 150. Now, later, this was after the development in 81 of diuretics, it was indeed improved so much. And then, of course, you can see that this indeed is a huge success story of diet and early drug treatment. Now, what about salt nowadays? You can see there is a huge, large distribution of different salt contents. India, I would say, is a little bit above. No, it's in the middle, the same as in Europe. So this is at average. China and some parts of Mongolia, they have an excessive salt intake. And indeed, this was published in the New England Journal of Medicine, and the surrogate of sodium intake is salt excretion in the urine. You can test it in your patients, and you can see if there is not enough salt, then it's a problem. But there is also sharp increase of outcomes of death for any cause and risk of cardiovascular events when there is too much salt in there. And indeed, the blood pressure value is okay. On the other hand, and that is a proposition of a lot of fruit intake, is the higher the intake of potassium is, such as in fruits, if the patient is not in renal failure, it can provide indeed a benefit. You can see low potassium intake or excretion, which is the equivalent, causes more events than high. And this potassium deficit is greater than low sodium diets. Now, what is indeed hypertension and salt? So there was one study which was fascinating. That was a study where there was a reduction in salt, and that was done in South America. They substituted salt in villages, and you can see that works, more potassium, less salt excretion in a huge population. You can see the numbers here. And there was a risk reduction of stroke by 14%. Please take into consideration that patients indeed need a reduction of stroke. Now, if there is blood pressure, where should we go to? This is the largest study on the achieved blood pressure values. And that was indeed driving the guideline recommendation in America, in Europe, and anywhere in the world. You can see major cardiovascular events and favors reduction per 10 millimeters of mercury. You can see all-cause death, but please look at this. If the blood pressure achieved is lower than 130, there is the strongest blood pressure reduction you can see by 37%. So strict blood pressure goals are important. One of the major driver of these complications is stroke, and therefore indeed these low blood pressure values should be taken into consideration. 600,000 patients, so that is our goal. And that is indeed our goal also concerning all-cause death. And that is one of the reasons historically why the guideline-directed target values become lower and lower. You can see Jane C4, 84, 88, 90, and so on. We are now here in 220 to 230. So these are the guideline-directed medications, and that is now where we really got very, very strict. This is diastolic blood pressure. Here's the SPRINT trial and the HOPE-3 trial. So being strict with blood pressure control is very important. So I brought this from the ESC recommendation. The blood pressure should be categorized as non-elevated, elevated, and hypertension. Hypertension is above 140. This is above 130, and 120 to 130 or below is normal. And then, of course, the risk is particularly low. Now, here you can see the data for the other blood pressure measurements. Non-elevated is the same. Elevated is always a little bit lower when it comes to ABPM and also when it comes to hypertension. So these patients are hypertensive. At night, the blood pressure goal should be below 120 to 70 because a high blood pressure at night provides and is associated with the greatest risk for cardiovascular outcomes. Now, why is it so? And indeed, why should we go to target values? This is a SPRINT trial. We recently had at the American Heart Association, I will show you, had this also in diabetics. These are non-diabetic populations. There was a lenient blood pressure control called standard therapy between 130, which is elevated blood pressure. You see this is a blood pressure, and this is a strict blood pressure control, taking into consideration true normal blood pressure. And here you can see what the outcome is. Primary outcome, MI, stroke, cardiovascular death, reduced by 25%. That is the difference between 135 and 122. So therefore, strict blood pressure control. The difference starts at 1 year, and death from any cause, same things, risk starts from 2 years. So you protect your patients by more than 25 or 25%. Strict blood pressure control. The other thing, what is the interesting parameter in blood pressure? Where should you look at? So I have a question for you. We do not have a chat, so I don't wait for your answers. But think of it. There is a blood pressure of 102 patients, 190 to 92, and another one has 180 to 68. So these patients had higher systolic blood pressure, but these patients had considerably lower diastolic blood pressure. So what is the answer? These are data from the SHAP trial where you can see the risk and systolic blood pressure at baseline, and here you can see diastolic blood pressure at baseline. You can see that there is from 80 onwards, there is the risk here lower the higher the diastolic blood pressure is, and the lowest diastolic blood pressure at a very high systolic blood pressure confers to a higher risk. I will talk to you in a minute why that is so. Here is patient 1 with the higher systolic and higher diastolic blood pressure. This patient on the ordinator's risk has a higher, has a lower systolic blood pressure, but a lower diastolic blood pressure is shown here. And this is a risk difference, which is it's 2.5% risk. So patients with a low diastolic blood pressure, they are particularly at high risk. And this is something which is related to age. You can see there is a continuous rise in systolic blood pressure, depending on baseline blood pressure. So these are hypertensives, normotensives, and high blood pressure people. So this is indeed the blood pressure when it's very low. But what they all have in common that the blood pressure diastolically drops approximately at 60 years. Approximately at 60 years. And then you can see a drop in blood pressure here. Of course, that means that the blood pressure types are different according to age. Elderly people have higher isolated systolic blood pressure, and that is what is really important because that confirms to the highest risk. And why is it so? Because atrial stiffness is important. So a low diastolic blood pressure shows you that there's already end organ damage in the vasculature. These vessels are already stiff. And the background is that when there is a beat of the heart, it is accommodated by an elastic artery system. And if it's stiff, it's not accommodating the reservoir function of the vessels are not there. The problem is that in young people in systole, the blood pressure is transported through the vessels, and in an elastic vessel, there is a very slow reflection of the wave, entering the heart in diastole, increasing coronary perfusion pressure. If there is stiff artery in an elderly, the systolic blood pressure and the wave is indeed very fast, and this is 7 meters per second. That means the reflected waves hits the systole of the heart. And the consequence is vascular mismatch, increase in afterload, and this is associated to hypertrophy and to heart failure. And as coronary perfusion is low, and there is no diastolic support of coronary perfusion, it is not only an increase in demand of oxygen, but also of the supply of oxygen. Here you can see an experiment where this has been shown. This is for our students. This is a rigid tube. Please look here at the high blood pressure during a constant volume is pressed through it. And this is the pressure in an elastic aorta, which is mimicked by this experiment. You can see only a small increase in pressure. High pressure in a stiff, rigid tube. This is the elderly individual, and the younger individual is shown then when there is here a smooth reservoir function. And therefore the question is, what shall we do with the elderly? And this is the guideline recommendation. That means, of course, because they have more side effects, it is easier maybe to tolerate higher blood pressures. That does not mean that, oh, this is a misunderstanding, frequent misunderstanding. It should not be targeted 140. It should be targeted 120 to 130, but it indeed, one should not be too sad if it's not tolerated with 140, because blood pressure reduction in the elderly is as good as in younger individuals. This is a huge study published in 2021. The blood pressure reduction, there is no heterogeneity significant, should be done in elderly as well as in younger people. But if there are side effects, intolerance, you should not be too strict with the elderly. And this has been shown. You can see catastrophic blood pressure values at baseline in the very important Hypertension study. Yeah. And you can see that the blood pressure was reduced, but not to normal levels, still much too high, systolic and diastolic. And what happens is a huge reduction of stroke and an even bigger reduction of heart failure. And this increases independent life of elderly patients, less stroke, less heart failure. Therefore, it should be indeed followed. And that was studied in the SPRINT, lenient against strict blood pressure control in the fit and in the less fit individuals. One can make a personal decision on it, but the intensive blood pressure reduction is always better in fit and less fit individuals at high age. And here the SPRINT group, they extended it to frail patients, still there is a reduction of outcomes. Now there is a big discussion on the following, and we looked at that among others in the on-target trial, patients after stroke or MI. That is the so-called J-shape or U-shape curve. This is cardiovascular death and stroke, MI, and heart failure hospitalizations. And you can see the nadir is approximately at 130 to 120. That's the best values. This is achieved blood pressure, and at lower blood pressure, it goes up again. This is a tricky point. In diabetes, it's exactly the same, but the risk is elevated. The red ones are the diabetes. At high blood pressure and low blood pressure, the risk is higher in diabetes and non-diabetes, but the pattern is the same. Best reduction is 120 to 130. So why is it so? Nobody exactly knows. There are controlled trials in diabetes, and the low blood pressure below 120, below 130 is the best, where you have the best effort. Some J curve occurs, but not in stroke. But stroke is the most important thing, therefore strict blood pressure control also in patients with diabetes when it really comes to high risk. Now I come to the question how to adjust blood pressure. Risk prevention and treatment. Hypertension is usually prevention. And there is something where blood pressure in the early stages of the cardiovascular continuum, the risk is mainly driven by blood pressure, stable patient. And then, of course, you go to heart failure, and then you have neuroendocrine activation and inflammation as a predominant causes for outcomes. But in this case, of course, blood pressure is so important. But is there a direct effect of some drugs inhibiting vascular events? So this is a very interesting meta-analysis in heart failure trials. And the people from heart failure do not die from vascular events, but they looked in the SOLVE trial, the old trial, SAVE, TRACE, and have seen when you put them all together with very low event numbers, you have a positive finding in patients who have ACE inhibitors on vascular events. And indeed, that was the baseline of the HOPE study, providing in patients without heart failure a benefit of ACE inhibitors to reduce stroke, MI, and cardiovascular death by 27%. So RAS inhibition is important to reduce vascular events, including stroke. So it's not only heart failure, it's also vascular events. And the telmisartan study on target has shown the same. You can use either telmisartan or ramipril if you are very strictly adhering to the guidelines. Now, this is important, achieving blood pressure. But now how to achieve in blood pressure? Take this in the vascular patients, take other drugs in patients prone for stroke or prone for heart failure. So that is why I have the next type here. So which drug for which patient? This is a meta-analysis by Kostas Tomopoulos. He's done the best meta-analysis, but don't look at that. I will summarize it here. So all drugs reduce the cardiovascular risk. Blood pressure is key. It should be at a target between 130 and 120. Diuretics are superior to prevent events. You reduce overload. Should be one part of treatment. Beta blockers are inferior for stroke prevention. That is based on the LIFE study compared to losartan. That is an old study. Beta blockers have intermittently withdrawn from the guidelines. Now they are in patients who are non-controlled or have cardiac symptoms such as rate control for atrial fibrillation or angina or heart failure. Calcium blockers are superior to avoid stroke, but inferior for heart failure, and ACE inhibitors, of course, better for coronary events as shown before and heart failure. That is the baseline of hypertension treatment. But key is that you achieve the blood pressure goals. Yeah. So now how to do it? Adherence is a big problem. Patients, and this is a classical study which is always cited, patients have a different adherence. With beta blockers, after 1 year, only 50% of the patients taking their drugs. It is better for 81 blockers and ACE inhibitors. Calcium antagonist is intermediate. Altogether, that is very poor. So what can we do about it? This is the 5 years risk, 4 years risk. The effect of non-adherence is huge. We looked at that in the on-target trial. Cardiovascular death, stroke, MI, and heart failure. Patients who are adherent all the time and indeed are adherent for a long period of time have this increase of events after they have become non-adherent. Patients who stop at 1 year, 2 years, 3 years, 4 years, they have an early sharp rise of outcomes in death, stroke, heart failure, and hospitalization. So getting off the drug is very problematic, yeah, because you can see a huge increase of cardiovascular outcomes. And therefore, we have to make sure that patients take their drugs. That is absolutely key. So how to achieve that? We can facilitate it. We cannot avoid it, but we can facilitate it by applying combination therapies. That is what the guideline is recommending. European Heart Society of Cardiology guidelines 2018, 2024 ESH guidelines 2023, all the same. ACE inhibitors, calcium blockers, and diuretics in the combination, one pill combination. That is important. If there is resistant hypertension, one might add spironolactone as first class, or then, of course, a beta blocker, alpha blocker, or others. That is something which is important, but single pill is key. Why is it so? That is the combination of a diuretic and a calcium blocker that causes natriuretic and vasodilatory effect, a fall in blood pressure, but there is a counterregulation, and that is an activation of the renin-angiotensin-aldosterone system. That, of course, attenuates the effect of the diuretic and the calcium blocker, and that inhibits the dose-response relationship. So we need, by RAS activation and inactivation, to restore it. Patients are different. Some have a low renin hypertension on the right-hand side, high sodium and high aldosterone on the right-hand side, high renin, low aldosterone. So take aldosterone-renin ratio. Now, this, of course, acts as a different response to drugs in hypertension with these different combinations. They respond best to eliminate sodium with the diuretic. They particularly benefit with an ARB, and they, of course, have also a strong effect if there is a high aldosterone to spironolactone. Now, that is how we have a differential treatment, and showing this telmisartan amlodipine, you can see the dose-response relationship of amlodipine is restored by telmisartan. Yeah, this is the blood pressure reduction here, and vice versa. So therefore, combination therapy is key. It reduces adverse effects. Less hyperkalemia is shown here. And when you then combine without hyperkalemia, when you respond with low hyperkalemia, then you, of course, you can have less adverse effect, less edema when you add here an ACE inhibitor because of venous pooling. Now, if you do so, then you have a better adherence, approximately 20% in a single pill combination. Better adherence, you have also better blood pressure control and outcomes. This is a study which is quite new on outcomes in patients who have a fixed dose combination, and you can see a reduction of mortality as it is shown here. Yeah, the same, by the way, applies also for lipid-lowering drugs. What is new now? Combination at a very low dose. This is the Quartets single pill study. They added at really tiny doses, 81 calcium blocker and bisoprolol and indapamide. And then you can see compared to higher doses and less combinations, initial monotherapy, you have a sharper drop by 10 millimeters of mercury first and early on, and a much better blood pressure control in these patients. So combination therapy is key, even though the maximum doses are not achieved. Now, what about innovative drugs? This is now the ACC. There was one other important thing with resistant hypertension. This is a study which was recently published by Markus Schleich from Australia, the Precision study. And they looked at the dual ATA-ATB endothelin antagonist, aprocitentan. You can see a significant drop in blood pressure, which is slightly dose dependent. So 25 milligrams is efficacious. And then you can indeed drop the medication, and still there is a drop in blood pressure at the highest dose. So that is fine. It's a treatment for resistant hypertension. It's a significant drop in blood pressure. Most importantly, there is also a dose-dependent drop at night. Nighttime carries the highest risk of blood pressure, and when it's withdrawn double-blindly, still the blood pressure remains low. That is a strong argument in favor of these drugs. What about the American College of Cardiology? There was by Dr. Guang Wang. He presented up a sub-study where they looked at microalbuminuria in patients with diabetes and treated with SGLT2. They were looking of whether the endothelin antagonist reduces microalbuminuria, and indeed it did so, and most likely in the presence of SGLT2. What does it mean? It does not mean that they are additive or something, but the effect of the endothelin antagonist to protect the kidney is maintained even in the presence of SGLT2. We will see whether this will be approved. If so, then for resistant hypertension, but it might be a very important add-in to our therapy. The other one is aldosterone synthase inhibitors. They are now developed by some companies. Yeah, this here is one of them. That's the Target-HTN randomized trials. You can see different doses, and you can see the drop in blood pressure, systolic blood pressure, lorundrostat 25 milligrams and 50 milligrams, a dose-response relationship. And then you can see here placebo. There is a significant drop of approximately 15 millimeters of mercury. So what was new now in patients, in resistant hypertension patients, this was here at the American College of Cardiology proven. They switched to a fixed combination with indapamide and olmesartan, and if necessary to amlodipine. So these patients had 3 drugs were uncontrolled. This is resistant hypertension, uncontrolled, some of them resistant, those who were requiring 3 drugs, and they did a drug dose response relationship. And indeed, that was for a study, nicely powered study, 50 against 50, and then augmented to 100 milligrams. And what you can see, 50 appears to be enough. In those resistant patients, there was a drop in blood pressure by 15 millimeters of mercury. This is here placebo. It's about 7 to 8 millimeters of mercury, and this amounts to renal denervation. Another innovation is, so keep that in mind. There are a lot of studies now. There are some companies planning secondary prevention trials, heart failure trials. They want like to combine it. They want to combine it with an SGLT2 inhibitor. There is a lot of movement in the field to see whether this is intelligent, and the intelligent approach is SGLT2 inhibits the hyperkalemia, and then this will also be developed together with an SGLT2 inhibitor. Now, what about other drugs which are innovative? Silebesiran for hypertension. You can see that this is a antisense silencing RNA for angiotensinogen in the liver, drops angiotensinogen. This is coupled to a GalNAc system. It has a receptor on the liver cell surface, and thereby it is incorporated into the liver cell, and thereby providing inhibition and a degradation of the coding DNA for angiotensinogen. This was shown here. Silebesiran has a strong reduction of blood pressure, and this is a change of angiotensinogen over time. You can see 8 weeks, but you can see that lasts for 24 weeks, and therefore we have a 6 months of action in these patients. It's a very long-lasting effect that overcomes all the problems of adherence. We will see how this is developed, and there is a strong association in relation to this drop in angiotensinogen. We will see of whether this is the future. There is also planned severe hypertension study and potentially also a secondary prevention study. If that runs, it will be very interesting. And again, nighttime blood pressure is reduced, no problems of adherence, circadian 24-hour reduction of blood pressure, in particular in the night, which is important because this drives the event rate. Now, finally, last drug, renal denervation. You know this history, sympathectomy, a big operation in the kidney, getting rid of these sympathetic nerves, was able to reduce blood pressure and very old study to improve mortality in patients who had very poor medical treatment because at that point of time there was almost no drugs. Now, what do we do now? We have renal denervation, sympathetic activity traffics to the kidney, and then it traffics back to the brain, vicious cycle, and increases blood pressure. We have 3 different devices. Ultrasound and radiofrequency is now approved in Europe and the United States, I think in India as well. So that will become important. And there was this study, which was the approval study for radiofrequency. There is a drop in systolic blood pressure. This is sham controlled. And the same in office, and this is ABPM, significant blood pressure reductions, very strict control study. And this is for the ultrasound, same thing, blood pressure reduction at day and at night, and always on, no problems with adherence. That is the future, I think. And we have a reduction by 20% or more than 30% of hypertensive emergencies in the emergency room. That is very important. There will be a more detailed analysis, and the paper has just put it together now. It works over 3 years. There is no signs of reinnervation. There is a difference at 3 years, although many patients crossed over here, right? You can see the drop here. But at the end of the day, there is a stable difference in blood pressure after 3 years. This might be another important argument for a broad implementation. And these are data from our groups, and we gave data for indeed 10 years. You can see it was rather safe concerning the eGFR decline, but blood pressure reductions are maintained over 10 years. So no signs of reinnervation. This is just from the ACC. I presented data in patients with a cardiorenal metabolic syndrome. That means diabetes, kidney disease, and hypertension. And you can see the blood pressure drop is exactly the same. Hypertension with metabolic syndrome, it looks like slightly less, but it was not significant. And there was also a similar change of kidney function, indicating that it is safe in these patients with this significant comorbidity. And then there is a little bit less medical treatment in these patients. So the recommendation now is it can be used in uncontrolled hypertension. The patients must like it. Maybe some patients do not want to take drug. And then you have a 10-year reduction of blood pressure, saving 1 or 2 drugs. You will not eliminate blood pressure drugs at all, but you can save it and you make the blood pressure and bring it into a better control rate. So this is now for resistance hypertension what we have. We have spironolactone. This is a new guideline from the ESH. I show you this time. You have spironolactone, or if there is kidney failure, you try chlorothalidone, then beta blocker, alpha blocker, but also consider renal denervation in patients with an eGFR above 40, because we do not have data in lower ejection fraction. We're just working on it. It might also be entering that field, but still we do not have the data in kidney failure. So conclusions, we have a huge problem. It's the largest problem in cardiovascular prevention. Treat blood pressure to low targets, 120 to 130. Treat also accompanying risk factors, then you have an over-additive reduction of the over-additively increased risk. So therefore, be very consequent in doing that. Use combination therapies to overcome adherence problems. Don't forget, indeed, the choice of drugs according to comorbidities, kidney disease, obesity nowadays, and also do not forget alternative treatments such as renal denervation. Thank you very much for your attention.
Thank you, sir, for that wonderful presentation. So we now open the forum for discussion and audience Q&A. So I invite both Manoria sir and Dr. Bohm sir for the session, for the discussion.
Are there any questions in the chat box?
Sir, I've shared with you in the chat box.
This question is for Dr. Michael Bohm. New drugs for hypertension are in the pipeline: zilebesiran, lorundrostat, aprocitentan. How will these be important in managing hypertension in the current scenario? You have already discussed in detail. So, Dr. Bohm, one basic question for the physicians is, what is the ideal way for diagnosis of hypertension? Is it office blood pressure, home blood pressure, or ambulatory blood pressure? What is the best way?
That is interesting. So first of all, it should be taken regardless of how you can do it. So you take what you can. I think in many countries, in many regions, in my country, in your country, it's not always available. For patients, of course, they have to take it for 24 hours. That is bad. So what we do, we take blood pressure, and that would be the first step in every patient. Yeah, in a sitting position at rest, not when he's just hurrying up the stairs. And then if that is pathological, the practical recommendation is then always to do an ABPM. In ABPM, you have the further classification into patients who have a normal blood pressure at home in ABPM. Then we call that white coat hypertension, which is not conferring to an elevated risk. These are patients who will get in the future fixed hypertension, so then they should be controlled very closely. And then you can have patients who have really hypertension, and you can see that patients who have a nighttime blood pressure, which is high, have a particular high risk. That is the next information you can have. And then there are patients where you think they might have hypertension concerning their risk, and they have normal office blood pressure, but they have a pathological ABPM, and that is called masked hypertension, and they have the highest risk. And in these patients who do not dip at night, who do not maybe have normal office, but an elevated blood pressure at home and at night, they are highly suspicious of secondary hypertension. And then you look at the urine, Con syndrome, renal artery stenosis, and endocrine tumors, or whatever you like, depending on the height of the blood pressure. But this is a very practical approach.
The second issue is the criticism for ambulatory blood pressure, particularly when it is this inflating the arm. People say when the arm is inflated in the night, the patient gets awake, so it may not be true nocturnal blood pressure. So, what is your viewpoint on this, and how do you look at the cuffless ambulatory BP monitoring?
That is true. There are, of course, in the ABPM artifacts, the first one, or this is not an artifact, that is simply due to the measurement. That is when the patient sleeps not well. Yeah, can happen. But the other thing is sometimes you have excessively high systolic and diastolic blood pressure. Then at night, the patient was lying on his cuff. That is the other artifact you can see. And indeed, this technique has limitations, definitely, but still it is the best, right? It is less confounded as office blood pressure. Yeah. And you can see it if the patient has a high heart rate at night, then you know he's awake. If the high heart rate is very low and he has extreme peaks of blood pressure, then it's an artifact. And by eyeballing, you just subtract these uncertainties. And then I think you are doing quite well looking at it.
The mortality in a controlled hypertensive is 1.5 or even 2 times compared to a normotensive individual. So, what can be done to minimize mortality in controlled hypertensives?
So the point is mortality is driven by hypertension, but hypertensive people, when they're obese, they have also 50% of diabetes. Yeah, also India, of course, has a problem there. And then, of course, to reduce mortality, that means you need an approach which addresses all kinds of risk factors and complications. And that means you need to also look at this at the lipids, at diabetes, and it is always an approach addressing all kinds of risk factors. So the global risk, which is there, and then it should be fine, right? And then of course you have an effect on total mortality in the long run.
Indians are hypersympathetic and they have higher heart rate. Some of the trials from the West have shown that even your hypertension is controlled, you have increased heart rate, there's increase in the cardiovascular events. So how do you look upon this, and do you have any trial where in a controlled hypertensive patient the heart rate was reduced by, say, lifestyle modification or drugs, it decrease in the cardiovascular events?
Yeah, that is a very interesting question, but on the other side, it is a very, very difficult question. So what we know in hypertension, that there is an association of heart rate to outcomes. This is in the normal population, that is after MI, and also in the hypertensive populations. That's what we know. What we do not know is whether a reduction of heart rate leads to a reduction of mortality and outcomes. And it is in press in the European Heart Journal, a paper I did together with Tomopoulos. This is the Greece scientist with excellent skills in meta-analysis. We looked at the beta blocker data all since many years, all what is available. And there it turned out that in uncomplicated hypertension, the effect of heart rate is below that of hypertension. There is no treatment effect. If high-risk hypertensives, if they have a certain degree of metabolic disease and in particular heart failure, immediately when the ejection fraction is reduced, then you have a beneficial effect on beta blockers. And we know that the effect of beta blockers are mainly driven by heart rate reduction. We know that from heart failure research. So you can see we do not have a complete investigation in hypertensives. That is a big problem. Well taken.
Sometimes we have patients, particularly in the Indian context, they are long-standing diabetics. The glycemic control is inappropriate. They have CKD, they have severe autonomic neuropathy. So lying down blood pressure is very high. When they stand, the blood pressure becomes very low. They have syncope. So how do you manage these patients, high blood pressure control in these difficult patients?
Um, It is difficult. So again, comorbidities, kidney disease, SGLT2 inhibitors, of course, because these people do not have hypertension only. The blood pressure is just one aspect. And if they are sick enough, the blood pressure will drop even, and then you have a heart failure patient. So the transition from hypertension to heart failure is very, very, very rapid and fluent there. So these patients who have a heavily moving blood pressure with a high variable blood pressure over 24 hours, for instance, they are difficult to control because when you cut the peaks, then you have hypotensions at other time points during the day. And what we know at least is that these 24 hours fluctuation, smoothness index is called, is associated to cardiovascular outcomes. When you see this, then you can see immediately on ABPM that this is a very difficult patient to be controlled, right? Long-acting drugs, accompanying risk, yeah, do not drop them too much because then they get rid of the drug and will not take them. It's another practical point.
Sometimes we see supine hypertension instead of hypotension. So, what does it imply and how do you manage? The patient gets up, the blood pressure is high on standing compared to lying down.
That is an indirect sign of an autonomic dysregulation, and this can be due to secondary hypertension. Yeah. So look in these patients, look into maybe not the 24-hour urine, that's what we did before, but look also in the serum for catecholamines, for hydroxyindole acid, and all these kind of things for endocrine measures. Look at aldosterone, renin, aldosterone ratio, and look whether you have an autonomic secondary hypertension. Do not forget the duplex of the kidneys. Yeah.
In diabetics, we often talk of glycemic overload. In hypertension, people are talking of BP overload. So, how do you look upon this concept of a BP load? Taking it from the ambulatory BP monitoring, is it relevant or what is the data on this?
So if I've taken you correctly, what is the role of hyperglycemia in these high blood pressure? So
No, BP. In diabetes, we talk of glycemic load. In hypertension, people talk of BP load on ambulatory blood pressure monitoring. The BP hypertension is for a longer duration of time. So, do you think this is important or not?
Absolutely, I think it's a principle. So we take about smoking. We take 40 packs history, yeah. So that is how much he smoked in 40 years. Now we know that LDL has a total load of LDL over time is important. My personal opinion, although it's not really well studied because you need a lot of lab data, is HbA1c load or glycemic load, as you said and you named it, and the same will be for blood pressure load. It's not only a time point and the height of the blood pressure, it's a time where blood pressure and glycemia is present, and that gives you a cumulative evidence. In blood pressure, we have now a new parameter for blood pressure control in trials, and that is time in therapeutic range. Yeah, you have serious measures of blood pressure, and then you can see how many percent are in range, and that gives you a rough estimation of the time being not in range. And that I think addresses your questions directly, right?
One of the problem which keeps on bothering me is then these patients of resistant hypertension not responding to drugs are subjected to renal denervation. How one decides whether the procedure has been adequately completed? Angioplasty or stent we see directly or by IVUS or OCT or even by angiogram. So how do you decide? Is there any test to know that you have performed a good procedure of renal sympathetic denervation?
So first of all, to perform the procedure, we do ultrasound, and then we do an angiography, and we are ready to do a PTCA or a PTA with a stent implantation and renal denervation. In trials, it's not allowed in clinical practice. I would like to get the blood pressure fixed if there is renal artery stenosis. The big question of the future is whether it makes sense to apply both of it, right, together. First, you denervate, and then beyond the stenosis, and you put a stent in. And I think your question is very critical concerning how do you know whether the procedure is adequate? Honestly, we don't know. Yeah. What we know in the new trials, we do as much as possible. So we have ablation points up to 40 to 50. There are studies who put a pacemaker in the renal artery, paced it, and then looked at the blood pressure increase. It is reduced after renal denervation, but it is very painful, and you do not know whether renal denervation has also interrupted pain fibers, right? So it's not reliable. And so we do simply, honestly, do not have an on-site measure of whether we have been maximally effective. That is an open question still.
What is the average time elapsed after which maximum reduction in blood pressure occurs after renal sympathetic? Suppose somebody gets renal sympathetic denervation today. What is the time lapse after which maximum fall do you expect? Or is it variable?
You mean the time when the blood pressure is dropping? It's not immediately. That is important. So you do the procedure and you will not find low blood pressure the next day. And that is very good, I think, because it's good for safety. So what renal denervation is doing, it is readjusting the system very slowly. Yeah. So we know that the trials have done, you see a blood pressure reduction between 3 and 6 months. That is where you see it. And what we observe and I think there are speculations, you can ask me for speculations on that, the blood pressure decrease is increasing over time. So maybe that is a depletion of sodium in the vessel, which takes longer. It could be a deremodeling in the periphery, less pulse wave reflection, that can happen. But it is stable over time. It's even increasing over time, and it's not immediate.
The diagnosis of hypertension is easy. We have very cost-effective drugs in the Indian context to control hypertension. All these drugs decrease morbidity and mortality, improve the quality of life, but they do not decrease the number of hypertensive patients. The number of hypertensive patients are progressively increasing. So what is your viewpoint on primordial prevention? Is a long-term plans which could decrease the number of hypertensive patients?
So I think the numbers of hypertensive patients is increased by our societies and by, of course, lifestyle. Yeah, I mean, obesity is a major driver in hypertension. Maybe anti-obesity programs, exercise. Yeah, we all work in offices and hospitals and not anymore on the field, which might be better. Daily life activities like going shopping, doing exercise, all these things. The lack of these things are contributing to the high prevalence in many societies, not only India. We have it in Europe, any place. In particular, within Germany, I'm in a place where obesity is very prominent. In Germany, it's very small compared to India, but we have about 30% differences in obesity prevalence within this small country. Yeah, this is tradition, this is lifestyle, this is eating habits, drinking habits in Germany, of course, and that is all coming together. And this is the social medicine aspects we need to address to reduce the numbers. But once they have hypertension, then we need the drugs and the interventions. Also lifestyle, of course. Salt.
The last key message from your side to the physicians, cardiologists, and the practitioners.
Could you repeat, please?
The last key message for the physicians, practitioners, and even cardiologists in the context of hypertension.
The final message.
Yes.
Make your patients aware of the risk of hypertension, even though it does not hurt. Make them aware of the contributing factors such as lifestyle, exercise, and make them aware of the necessity to get blood pressure and other risk factors controlled by drugs, and make sure that they really take their drugs. Yeah, even though they will react sometimes a little bit annoyed, push them. That's my final message.
It was indeed great pleasure interacting with you, and all of us enjoy the flashes of your expertise during your discourse, and hope to meet you again with the newer interactions in the context of hypertension. Over to the organizers.
Thank you very much for the nice, kind invitation. Thank you very much.